Greetings everybody. Welcome to the Clinical Foundation series in Pain Medicine by Doc Tutorials. I am Dr. Randheer Annaram, Lead Consultant, Pain Medicine Department at KIMS Hospitals, Gachibowli. We are going to discuss about a very interesting topic, acute versus chronic pain today, and it is one of the basic topics that is necessary for every practicing clinician as such. So let's go ahead. So we'll understand the continuum, the mechanisms that is involved, and the management approach as well. So what are the learning objectives for today is how to differentiate between acute and chronic pain by definition, duration, and underlying purposes. Then you describe the classification of pain by origin. That is mechanistic classification as such. Then you recognize the global prevalence and everything. Then a basic pharmacological and interventional management options that are available. Know about the current guidelines and also how to communicate with the patients that have these pain, who are suffering from these pain. What is pain? The IASP definition, what is the International Association of Study of Pain, says is pain is an unpleasant sensory emotional experience that is associated with or resembling that to be associated with actual or potential tissue damage. See, definitely pain as an experience, it is a sensory experience that a person faces. But when we are seeing about the definition, it says it is unpleasant, definitely yes. But what is extra is the associated with or resembling that associated with actual or potential tissue damage. What is actual or potential tissue damage? Imagine there is some tissue damage that is about to happen or that has already happened. So you get an injury, any damage that happens, any trauma that happens, that causes nociception. Okay, so it can be that there is actual tissue damage or there's going to be ongoing or potential tissue damage like ischemia. Okay, that may lead to tissue damage, but it is already causing pain to actually show the body, tell the body that there is an injury that is going to damage the do bodily harm. Okay, so we understood the actual or potential tissue damage. So it is associated with actual or maybe potential tissue damage. But what is or resembling? What does or resembling mean? Or resembling that to be associated with means that there can be a potential tissue damage, or such kind of tissue damage can be similarly taken up by the body and thought to be of bodily harm, and then a pain experience can be there. So this resembling that to be associated with is a new word that has been added to the newest definition of pain, okay, in the year 2020, right? So this is the most important word that is necessary for introducing a new type of pain that has been introduced in 2020. Okay, we'll discuss about that later. Okay, so pain is always personal, and along with the definition of pain, there are other 6 notes, key notes that have been given with the definition of pain. Okay, right? So this key notes of definition of pain is always personal, subjective experience obviously, and is influenced by the biological, psychological and social factors. But many a time we as clinicians do not consider all of these things. We do not ask the patient, we do not take a probe of the history about the biological, psychosocial and social factors, right? It cannot be reduced to nociceptor activity alone, right? Because we have already read, we have already spoken about in the definition as well, there can be a resembling that to be associated with component. So nociceptor activity, if even if it is there or not there, there can be experience of pain. So verbal description is not required for pain to be valid. So verbal description in the sense that sometimes the patients do not know how to explain their pain. They say that the pain is there, but they do not know where it is coming from, how it is coming. Okay, they do not understand as keenly as possible, okay, as clearly, as vividly that we want, as clinicians want, but they do experience pain. Okay, but pain is protective and has an adaptive role only in an acute phase. But when it turns chronic, this purpose of protection is lost. This is the main thing that we need to understand, that the protective mechanism is lost in chronic pain. Chronic pain is just not long term acute pain, it is entirely different, and chronic pain is a disease in itself. So when we know that the pain as an experience is not simple, it has many factors, many components, many factors that are interplaying for the patient to have an experience of pain. So there is nociception and there is pain experience. Both cannot be equal and both are very different. Both are very, very different, and some people can have so much of nociception but very less experience of pain, and some people have very little nociception but there might be a lot of experience in pain. That depends on many other factors. So let's learn what they are. Before that, we will make a core distinction of what an acute pain versus what a chronic pain is. So the acute pain is typically from 4 to 12 weeks. Okay, so this acute pain as such is sudden and is clearly linked to a disease or an illness. So the actual or potential tissue damage is always seen in the acute pain, and we know the mechanism, we know the injury, we know the illness, we can link the acute pain to the illness, right? It is a The purpose of acute pain is a warning, it is a warning signal, and it resolves as soon as the tissue heals. So nociception is in the origin of where the illness is, or where the injury or the issue is. So it can be injury, trauma, post surgical pain, okay, acute appendicitis, acute pancreatitis. We can always link the dots where the acute pain has arisen and where we can link it to the disease, right? The pancreas, where it starts, the acute pain is there, and the reason for it having an epigastric pain that gets better on stooping. Okay, and it is very, very severe pain, and we can link it very much to the illness. There is from the history we know in many ways that many times that patient has alcoholism as well as a habit. Okay, so chronic pain as such, how is it different? So it is not long term acute pain. Okay, it persists more than 3 months, it is not long term acute pain. Now it is altogether a very different problem. So because here the purpose of protectiveness or adaptiveness is lost. Okay, and it may expect more than the healing time. Okay, very usually you see some surgeries like acute appendectomy, mesh repair of hernia and everything. All these patients, they have undergone had their surgery, but they have the scar site pain even from months to years together, okay, after the surgery. But how much time does it take to heal? Only typically 1 to 2 weeks. Okay, they have some to no pain at all. Okay, but what if it is there after 1 month as well? Then it is subacute pain. Okay, and what about after 3 months? It is chronic pain, right? So this is entirely different, and it is going beyond the healing time. Okay, it is not, now the person doesn't have any illness as such. The incision or the surgical site has already healed. Okay, but still the pain is persistent. So the ongoing tissue damage cannot be reasoned here, but still the patient has pain. Most of the times the chronic pain is just not somatic pain like the acute pain that was there post surgery, right? So this can be neuropathic plus nociceptive plus some component of mixed pain. Okay, and there is something called nociplastic pain that we'll soon discuss, right? So the examples of chronic pain can be chronic low backache, neck pain, chronic neck pain, okay, chronic post surgical pains as such, okay, neuropathies, fibromyalgias, okay, phantom limb pain, post herpetic neuralgias, as well as complex regional pain syndrome, right? The most difficult and dreaded complications, pain conditions as such that exists. So what is the prevalence? Okay, out of all the people there is that live worldwide, all the adults, there is a 20% prevalence of chronic pain. 1 in 5 people do have chronic pain. Okay, they are suffering. Many of our relatives, elderly and people at home are suffering with one or the other chronic pain, like chronic knee pain or backache, sciatica or neck pain, which are the most common pain conditions as such. Okay, many of the diabetics have neuropathic pain, painful neuropathies as such. So out of 30 to 50% of the post surgical pains, patients report acute pain undertreated, right? So why is the undertreatment of pain? Many a time we consider pain as an experience to be normal post surgery, and it doesn't have to be. So in such cases we either treat pain less, or we always treat undertreated, citing the complications that may arise from the pain medications, right? So pain, chronic pain as such, is the leading cause of years lived with disability globally. Okay, so as age arises, there is more chronic pain, especially amongst the women, and there is also increase in prevalence in comorbid mental health conditions. Okay, people who have mental health conditions, especially depression and anxiety, have more experiences of chronic pain. As such, we do not know what is causing the other, but they do coexist. So there is a antecedent model and a precedent model. Okay, so the other one is the low back pain is single leading cause of disability. Roughly 10 to 20%, 1 in 5 people transition to chronic pain after surgery or trauma, right? So after you have an injury or you have a surgery, 1 in 5 patients go have injury, right? So is it essential to treat chronic pain? Yes, definitely, but more so, it is important to actually decrease acute pain leading into chronic pain, acute pain transitioning into chronic pain, right? So, we will next see the classification of pain. Pain as such can be classified by many ways. We have seen a prior classification on the time basis, acute pain versus chronic pain, right? So this acute, subacute and chronic pain, this is time based classification of pain. But there is another classification of pain, the mechanistic classification of pain, which is nociceptive, neuropathic and nociplastic pain. Okay, there is another more traditionally used, cancer pain and non-cancer pain. Okay, this is also a mechanistic classification, but nociceptive, neuropathic and nociplastic pain would actually fit our way to treat, because it gives the mechanistic approach. It also gives us the pharmacological approach to treating such pains by classification. Okay, many a time we actually have classification of pain that is mixed and matched to our requirement. Like we say, chronic non-cancer pain, chronic cancer pain, chronic neuropathic pain, chronic nociplastic pain. Sometimes we say mixed pain, right? Chronic mixed pain. So chronic mixed pain or chronic nociceptive pain, all of these things can actually give an idea of what sort of medications, of what kind of approaches do we do for treatments. Okay, so next is how to know the quality of pain and the patient perception. So we have the guides of mechanism. Usually we say that nociceptive pain may be sharp, aching, throbbing. Okay, nociceptive pain is again two types, somatic as well as visceral. Okay, if you see the last column, there is visceral pain, but the other one is somatic. Okay, somatic pain. Somatic pain is usually sharp, aching, throbbing, but the visceral pain as such can be cramping, colicky, deep, and poorly localized. The other somatic nociceptive pain is actually well localized. Okay, so when you approach a patient bedside, so when we ask the patient as to where his pain is, they actually point it out with a finger. So when you ask the patient, if the patient is poorly localizing the pain or is not able to express from as to where the pain is coming from, he might show a area in the body that the pain is arising from. Okay, he would say that he is not able to pinpoint with a finger. So I always ask my patients on the bedside if they are able to pinpoint their pain with a finger. If they can't, then you immediately think of the of a visceral pain. Okay, then there are neuropathic pain. So neuropathic pain is due to the damage or disease of somatosensory nervous system, right? So the neuropathic pain as such is expressed by burning, shooting, electric, tingling kind of sensation. Okay, these, or there can be a classic pins and needles kind of sensation. Okay, that can be seen. Okay, sometimes there can be altered sensory perception associated with neuropathic pain as well, like the paresthesias that associate with the neuropathic pain. So there is DNQ4 questionnaire that can help us to identify neuropathic pain. Okay, then comes the most important pain, the nociplastic pain. Okay, the newest type of pain that has been introduced in 2020, and this is why the nociplastic pain as such is has changed the definition of pain entirely by the International Association of Study of Pain. So, what is nociplastic pain? Nociplastic pain means that there can be a resemblance to actual or potential tissue damage, and that can cause the perception of pain. Okay, so there is no actually tissue damage, okay, but there is a resemblance, so there is pain, right? So such kind of pains are very much seen in chronic pain, and this is one of the features of chronification of pain. So nociplastic pain as such is very diffuse, it is widespread, may be tender to touch, and the patient again will not be able to reason or tell if the pain is very much localized in that area in many of the nociplastic pain conditions. Sometimes they do in cases like fibromyalgia where there are tender points in the muscles. So we will be able to press and elicit the pain or the jump sign in such conditions, but many a time the pain is usually diffuse and in a larger area, and there can be some points that can be very tender. Okay, so nociplastic pain is a new type of pain, and the conditions that we see in nociplastic pain very much so is fibromyalgia. You can also name phantom limb pain as phantom limb pain and CRPS as nociplastic pains. Then there can be IBS in which there can be pains that are nociplastic, right? There is myofascial pain syndrome that is nociplastic as well. So apart from that, why the patient perception matters is patient does not actually correlate his pain experience to the amount of tissue damage. So if you go, the most common example is the knee pain as such. Patients who have knee pain, their x-ray might be Kellegren-Lawrence grade 1 or 2, but their experience of pain may altogether be very, very high. So you do not expect the labs or the tests or the tissue damage that is visible to the amount of experience of pain that the patient has. Patient pain intensity can be a lot different, and fear, anxiety, and other prior pain experiences may alter. So, the prior pain experiences can actually help the patient in pain coping, and the patient might not experience as much as pain as somebody who's newly experiencing pain. Like the children, they have a lot of pain experience because of the fear. So how pain is reported and tolerated is entirely different. And catastrophizing, like dooming experience that everything is gonna go worse and bad, is known as catastrophizing. So this kind of perception that usually happens, especially we see in cancer patients, along with cancer pain, as soon as the pain increases, the patient knows that he is diagnosed with cancer, then he experiences something called catastrophizing. He thinks that everything is going to end. In such a case, the patient has a very good chance of making the experience go to chronic. Okay, so there is one more thing, is the most important thing of the patient perception is actually there is a nurse that she has given definition of pain, that pain is something that the patient says it exists, okay, whenever and wherever it exists, okay. So we have to trust the patient. That is where, when we start trusting the patient, that is when we will treat the patient, okay. So the types of acute pain are, there are four types. So there is post surgical, post traumatic, and pain, acute pain associated with medical conditions, and there can be procedural pain or labor pain as such, okay. So the post surgical or post traumatic pain, you understand, the pain with the medical conditions is acute pancreatitis, acute appendicitis, okay, MI, then there is renal colic that is there, okay. All of these things, maybe ischemia of the limbs also is pain with medical conditions, okay. So there is also the process of labor also comes under acute pain. Chronic pain is chronic primary pain or chronic secondary pain, okay. Chronic primary pain is pain condition as such. So fibromyalgia, chronic low back pain, complex regional pain syndrome that we earlier said. So all of these are chronic primary pain. So there is no proper underlying cause. But what is chronic secondary pain? So there is some amount of cancer related pain. The cancer is causing the pain, chronic post surgical, post traumatic pain, neuropathic pain, chronic pain secondary to musculoskeletal issues like osteoarthritis, chronic pain due to osteoarthritis of knee, okay, or chronic secondary visceral pain. So chronic pain due to chronic pancreatitis. So how does acute pain become chronic? So the tissue injury makes acute nociception activation, then that when given with inadequate pain control, that we generally undertreat the pain as such, along with the other risk factors that we have told, the fear, the anxiety, the self reliance, decreased self coping, catastrophizing, okay, all of these things are the risk factors that we have earlier discussed. Then nerve injury during surgery, there is genetic vulnerability for a few people. So all of these things can cause peripheral and central sensitization. So these are the mechanisms that are involved in making the acute pain chronic. There is not just peripheral sensitization, there is also central sensitization, which is the main component of chronic pain, and that itself is the mechanism, the central sensitization that we do not understand as physicians, that we are treating day in and day out, that chronic pain is entirely different from acute pain because of this central sensitization. So then the patient goes into a chronic pain state. This is how it transitions. And what are the treatment modalities? So there are pharmacological approaches. So usually we tend to avoid opioid medications for chronic non-cancer pain, right? So chronic non-cancer pain is generally not treated with opioids and non-opioid medications and adjuvant agents, along with the regular pain medications, the gabapentinoids, the tricyclic antidepressants, the SNRIs. All of these agents along with multiple medications are used to treat chronic pain, and we have to tailor make to their mechanism. So if it is neuropathic pain, it is entirely different. Then there is chronic nociplastic pain, it is different. Then sometimes it is just chronic nociceptive pain, like in osteoarthritis, the treatment is different. So what about the interventional pain? This is the core but not the only modality of treating chronic pain. Okay, many of the people just tell that pain medicine is all about interventions. No, it is not. Okay, pain medicine is about a holistic approach, a complete approach to treating chronic pain. Okay, because there is no one reason or no one factor that causes chronic pain. It is multiple modalities and multiple things that causes chronic pain. So all of these things, when they are put together, forms a pain experience as such. So this pain experience cannot be treated by one intervention as such. It is not 1 plus 1 in chronic pain treatments is not 2. 1 plus 1 is 11. So in the interventional approaches, we have nerve blocks, we have injections, we have radio frequency ablations, we have pulse radio frequency, we have neuromodulatory techniques like the spinal cord stimulators, the intrathecal pumps. Then we also have prolotherapies, we have regenerative procedures that can be done. Then there is cryotherapy. All of these modalities, there are multiple modalities that can be tailor made to actually cut down the cycle of chronic pain and assist the pharmacological therapy and the adjunct of pharmacological and interventional therapy along with physical rehabilitation makes the care wholesome. There are psychological interventions that can be helpful in managing some patients with chronic pain. We need the psychological support in managing. To summarize, 1 to 3 months is acute pain or subacute pain, and more than 3 months it can be chronic pain. So acute pain is always protective and adaptive, whereas chronic pain is always often maladaptive. Okay, mostly the primary mechanism in acute pain is nociceptive. There usually is less of neuropathic acute pain as well as nociplastic acute pain. It is very rare. Okay, but in chronic pain it can be mixed, it can be somatic, it can be visceral, it can be neuropathic, it can be nociplastic. So acute pain, everybody has an experience with it, but chronic pain, there is a 20% of patients living with chronic pain. The treatment goal is to resolve pain and treat the cause. Sometimes in chronic pain, we just try to reduce pain. Okay, we do not treat the cause sometimes. We just try to reduce the pain experience, and improve function and quality of life by doing it. The first line of therapy is either a non-opioid NSAID plus an opioid as and when required, strong opioids, versus a non-pharmacological non-opioid, right? The psychological role is minor and situational. It is mostly on the anxiety spectrum in acute pain versus the chronic pain, wherein there is a lot of depression that happens. It is the modalities that are there in managing chronic pain, like CBT or ACT, are central to it. These are my references, and thank you for the discussion.